Bismillah ar-Rahman ar-Rahim. Our subject today is an introduction to anemia and iron deficiency anemia. Anemia is defined as the reduction of the RBC volume or the hemoglobin concentration below the range of values occurring in healthy persons. There may be racial differences in hemoglobin level. Black children have levels about 0.5 gram per deciliter lower than whites and Asians, possibly in part because of the high incidence of alpha thalassemia in blacks. Decreased hemoglobin leads to decreased oxygen carrying capacity of the RBC. Physiological response to anemia. This includes first, increased cardiac output, second, shunting of the blood flow towards vital organs and tissues. Third, increased 2,3-DPG, that is diphosphoglycerate, which lead to decreased affinity of hemoglobin to oxygen. Fourth, with an increasing severity of anemia, there may be weakness, tachycardia, tachypnea, dyspnea on exertion, cardiac dilatation, and maybe congestive heart failure. 5, increased erythropoietin, leading to an increased RBC production by bone marrow, which lead to an increased absolute reticulocyte count, but sometimes bone marrow loses its usual capacity for RBC production due to bone marrow failure or what we call ineffective erythropoiesis, for example in megaloblastic anemia or thalassemia. That leads to normal or decreased absolute reticulocyte count or reticulocyte percentage. Normal RBC counts is about 4 million per cubic millimeter. Normal absolute reticulocyte count is about 40,000 per cubic millimeter. Normal reticulocyte percent is about 1%. Normal hemoglobin level differs according to the age state. For example, in cord blood, the mean is 16.80 gram per deciliter, ranging from 13.7 to 20.20 gram per deciliter. At 2 weeks, the mean is 16.5, ranging from 13 to 20. At 3 months, the mean is 12, ranging from 9.5 to 14.5. At 6 months of age, at 6 months to 6 years of age, the mean is 12 gram per deciliter, ranging from 10.5 to 14. At 7 to 12 years, the mean is 13 gram per deciliter, ranging from 11 to 16. An adult female, the mean is 14, ranging from 12 to 16, and in male the mean is 16, ranging from 14 to 18 gram per deciliter. Now we come to discuss approach to common cause of anemia. First, anemia associated with other hematologic abnormalities as that due to aplastic anemia, leukemia, and other bone marrow replacement failure. Second, anemia associated with reticulocytosis as that due to bleeding and ongoing hemolysis. Third, anemia associated with hyperbilirubinemia or increased serum lactate dehydrogenase is usually due to hemolysis, and we have to do a review of peripheral blood smears as follows. If there is spherocytosis, there will be hereditary spherocytosis, autoimmune hemolytic anemia, Wilson disease. And if there is sickle's forms, there will be possibility of sickle cell anemia, sickle cell beta thalassemia. Target cell may indicate hemoglobin SC disease. Hypochromic anucleated RBC may indicate homozygous beta thalassemia. Microangiopathy may indicate hemolytic uremic syndrome and thrombotic thrombocytopenia. And the presence of white cells and blister cell may indicate G6PD deficiency. The fourth part is anemia associated with lower than appropriate reticulocyte response, so I have to assess the RBC size as follows. If there is microcytic RBC, there will be a possibility of iron deficiency anemia or beta thalassemia, hemoglobin E disease, or lead poisoning. If there is macrocytic RBC, there should be assessment of whether if there is or there is no neutrophil hypersegmentation as follows. If there is positive neutrophil hypersegmentation, there may be folate deficiency, B12 deficiency, inborn error of metabolism. If there is negative neutrophil hypersegmentation, there may be what we call Diamond-Blackfan syndrome, congenital dyserythropoietic anemia, or Persson syndromes. Now we'll talk about iron deficiency anemia, which is the most widespread and common nutritional disorder in the world. It is the most common cause of anemia in children. It is estimated that 30% of global population suffers from iron deficiency anemia, and most of them live in the developing countries. In USA, 9% of children aged 12 to 36 months are iron deficient, and 30% of them will develop iron deficiency anemia. The body contents of iron is about 0.5 gram in newborns, about 5 gram in adults. About 1 milligram of iron must be absorbed by GIT each day. Because of the absorption of the dietary iron in the proximal small intestine is about 10% of the eating amount, so a diet containing 8 to 10 milligram of iron is required daily. During the first year of life, there are relatively small quantities of iron-rich food, so there may be deficiency of iron, so it is important that diet should be fortified with iron. Adolescents are also susceptible to iron deficiency because of increasing requirement due to growth spurts, dietary deficiency, and menstrual blood loss. About 2% of the adolescent girls have iron deficiency anemia. Etiology of iron deficiency anemia: first, low birth weight and unusual perinatal hemorrhage. Second, dietary deficiency, failure of breastfeeding, delayed or improper weaning, ingestion of large amounts of cow's milk, ingestion of little amount of rich iron diet as iron fortified milk, meat, green vegetables, etc. In term, iron deficiency anemia due to dietary loss is unusual below 6 months of age and usually occur at 9 to 24 months of age. The incidence will decrease after that. The usual dietary patterns in infants with iron deficiency anemia is the consumption of a large amount of cow's milk, low iron content and blood loss from milk protein cheilitis, and of food not supplemented with iron. Third, blood loss, particularly in older children, as peptic ulcer, Meckel's diverticulum, intestinal polyps or hemangioma, inflammatory bowel disease, hookworm infestation, Trichoris trichura, Plasmodium, Helicobacter pylori, pulmonary hemosiderosis, menstruation in adolescents, chronic diarrhea, and cow's milk allergy. Fourth, intense exercise and conditioning, as occurs in competitive athletics in high school, may result in iron depletion in girls. This occurs less commonly in boys. Clinical presentation of iron deficiency anemia. Most children with iron deficiency anemia are asymptomatic and are identified by investigations. Pallor is the most important sign of iron deficiency anemia, but is not usually visible until the hemoglobin falls to 7 to 8 gram per deciliter. Pallor of the palms, palmar creases, nail beds, or conjunctiva. In mild to moderate iron deficiency anemia, that is the hemoglobin from 6 to 10 gram per deciliter, compensatory mechanisms, including increased level of 2,3 dpg and shift of the oxygen dissociation curve, may be so effective that few symptoms of anemia aside from mild irritability are noted. With hemoglobin level falls to less than 5 gram per deciliter, irritability, anorexia, and lethargy develops. Asystolic flow murmurs are often heard. As hemoglobin continues to fall, tachycardia and high output cardiac failure can occur. Iron deficiency anemia has non-hematologic systemic effects. The most important effects are impaired intellectual and motor function that can occur early in iron deficiency before anemia develops. There is evidence that these changes might not be completely reversible after treatment with iron, increasing the importance of prevention. PICA, the desire to ingest non-nutritive substances, can result in ingestion of lead-containing substances, leading to plumbism. And pagophagia, which is the desire to ingest ice, are other symptoms of iron deficiency anemia. Iron deficiency anemia may lead to decreased cell-mediated immunity and impaired neutrophil activity and increased incidence of infection. Laboratory findings of iron deficiency anemia. In a progressive iron deficiency anemia, a sequence of biochemical and hematological events occurs as follows. First, disappearance of bone marrow hemosiderines and decreased serum ferritin, followed by decreased serum iron, increased serum total iron binding capacity or serum transferrin, and decreased transferrin saturation, followed by decreased MCV and MCH, indicating hypochromic microcytic RBC, followed by RBC count decreases, and the blood smear reveals hypochromic microcytic red cell with substantial variation in cell size, what we call an isocytosis, which can be revealed as increasing RBC distribution with RDW. Reticulocyte percent may be normal or moderately increased, but absolute reticulocyte can show insufficient response to anemia. Elliptocyte or cigar-shaped RBC are often seen. Detection of increased transferrin receptors and decreased reticulocyte hemoglobin concentration provides supporting diagnostic information when these studies are available. White BC count is normal. Platelet count may show thrombocytosis, but in severe cases there may be thrombocytopenia. Bone marrow examination reveal hypercellular and erythroid hyperplasia. Occult blood in stool seen in about 1/3 of cases. In most instances, a complete blood count demonstrating a microcytic anemia with high RDW, reduced RBC, normal OATBC, and normal or elevated platelet count is sufficient for presumptive diagnosis of iron deficiency anemia. Other laboratory studies are as reduced ferritin, reduced serum iron, and increased total iron binding capacity are not usually necessary for diagnosis unless severe anemia requires more rapid diagnosis. Other complicating clinical factors are present, or the anemia does not respond to iron therapy. Differential diagnosis of iron deficiency anemia. First, beta thalassemia trait. It is a mild microcytic anemia which occurs in the pupil of Mediterranean area, Africa and Asia. It is characterized by an increased hemoglobin A2 and or increased hemoglobin F. Serum iron, total iron binding capacity, and serum ferritin are normal. There are increased RBC count, which is decreased in iron deficiency anemia. Normal RDW, which is an increase in iron deficiency anemia. 2 alpha thalassemia trait, an increase in blacks, Chinese, and Southeast Asia. 3 hemoglobinopathies as hemoglobin H, hemoglobin E, and hemoglobin C disease. 4 anemia of chronic disease and infection. It is usually normocytic anemia, but may be slightly microcytic in about 20% of cases. There are decreased serum iron, decreased serum total iron binding capacity, and normal or increased serum ferritin. 5 lead poisoning. There are increased free erythrocyte protoporphyrin, coarse basophilic stippling of the RBCs, and an increased blood lead level. 6 sideroblastic anemia. They are acquired or hereditary disorder of heme synthesis leading to dimorphic anemia, that is hypochromic, microcytic, and normal RBC, and mostly occur in adults. Prevention of iron deficiency anemia. Iron deficiency is best prevented to avoid both its systemic manifestation and the anemia. Breastfeeding should be encouraged with the addition of iron fortified series after 4 to 6 months of age. Infants who are not breastfed should only receive iron fortified formula, 12 milligram of iron per liter for the first year, and thereafter bovine milk should be limited to less than 20 to 24 ounces daily. This approach encourages the ingestion of food richer in iron and prevents blood loss due to bovine milk-induced enteropathy. When these preventive measures fail, routine screening helps prevent the development of severe anemia. Routine screening using hemoglobin or hematocrit is done at 12 months of age or earlier if at 4 months of age. The child is assessed to be at high risk for iron deficiency anemia. The treatment of iron deficiency anemia, the regular response of iron deficiency anemia to adequate amount of iron is a critical diagnostic and therapeutic features. Oral administration of simple ferrous salt, most often ferrous sulfate, provides inexpensive and effective therapy. A daily dose of 3 to 6 mg per kg of elemental iron in 3 divided doses is adequate. Ferrous sulfate has 20% elemental iron and is ideally given between meals with juice for 8 weeks after blood values normalize to re-establish iron stores. Intolerance to oral iron is uncommon in young child, but older children and adolescents may have GIT complaints. Parenteral iron preparation are only used when malabsorption is present or when compliance is poor, because oral therapy is otherwise as fast, as effective, and much less expensive and less toxic. When necessary, parenteral iron sucrose and ferric gluconate complex have a lower risk of serious reaction than iron dextran. Dietary counseling is usually necessary. Excessive intake of milk, particularly bovine milk, should be limited. Iron deficiency in adolescents gets secondary to abnormal uterine blood flows. Losses is treated with iron and hormone therapy. Follow-up of anemia is if anemia is mild, the only additional study is to repeat the blood count 4 weeks after initiating therapy, at which hemoglobin usually rising by at least 1 to 2 grams per deciliter and has often normalized. If the anemia is more severe, earlier confirmation of the diagnosis can be made by the appearance of reticulocytosis, usually within 48 to 96 hours of treatment. The hemoglobin will then begin to increase about 0.1 to 0.4 grams per deciliter per day, depending on the severity of the anemia. When anemia responds poorly or not at all to iron therapy, there are multiple considerations like poor compliance, incorrect dose or medication, malabsorption, ongoing blood losses, concurrent infection or inflammatory disorder, concurrent vitamin B12 or folate deficiency, or a diagnosis other than iron deficiency anemia. Blood transfusion is rarely necessary. It should only be used when congestive heart failure is imminent or if the anemia is severe with evidence of substantial ongoing blood loss. Usually with partial correction and starting iron therapy. Thank you very much.